M5500 each extended release tablet contains sitagliptin phosphate monohydrate in 64.25 mg each. 2 sitagliptin 50 mg metformin HCl BP 500 mg. Sitagil M51000 each extended release tablet contains sitagliptin phosphate monohydrate in 64.25 mg each. 2 sitagliptin 50 mg metformin HCl BP 1000 mg. Sitagliptin is a dipeptidylpeptidase 4-DPP4 inhibitor, which exerts its action by slowing the inactivation of incretin hormones. Incretin hormones, including glucagon-like peptide 1 GLP-1 and glucose-dependent insulinotropic polypeptide GIP, are released by the intestine throughout the day and levels are increased in response to a meal. These hormones are rapidly inactivated by the enzyme DPP4. The incretins are part of an endogenous system involved in the physiologic regulation of glucose homeostasis. When blood glucose concentrations are normal or elevated, GLP-1 and GIP increase insulin synthesis and release from pancreatic beta cells by intracellular signaling pathways involving cyclic AMP. GLP-1 also lowers glucagon secretion from pancreatic alpha cells, leading to reduced hepatic glucose production. The pharmacologic mechanism of action of metformin is different from other classes of oral anti-hyperglycemic agents. Metformin decreases hepatic glucose production, decreases intestinal absorption of glucose, and increases peripheral glucose uptake and utilization. Sitagliptin metformin is a dipeptidylpeptidase 4-DPP4 inhibitor and biguanide combination product indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. When treatment with both sitagliptin and metformin extended release is appropriate, the most common adverse reactions reported in 5% of patients simultaneously started on sitagliptin and metformin, and more commonly than in patients treated with placebo were diarrhea, upper respiratory tract infection, and headache. Adverse reactions reported in 5% of patients treated with sitagliptin in combination with insulin and metformin, and more commonly than in patients treated with placebo in combination with insulin and metformin. Renal dysfunction, e.g. serum creatinine 1.5 mg DL males, 1.4 mg DL females, or abnormal creatinine clearance. Metabolic acidosis, including diabetic ketoacidosis, history of a serious hypersensitivity reaction e.g. anaphylaxis, or angioedema to sitagliptin metformin or to one of its components. There are no adequate and well-controlled studies in pregnant women with sitagliptin metformin or its individual components. Therefore, the safety of sitagliptin metformin in pregnant women is not known. Sitagliptin metformin should be used during pregnancy only if clearly needed. It is not known whether sitagliptin or metformin are excreted in human milk. Because many drugs are excreted in human milk, caution should be exercised when sitagliptin metformin is administered to a nursing woman. Carbonic anhydrase inhibitors should be used with caution treated with sitagliptin metformin as the risk of lactic acidosis may increase. Careful patient monitoring and dose adjustment of sitagliptin metformin and/or the interfering drug is recommended in patients who are taking cationic medications that are excreted via the proximal renal tubular secretory system.